everyone again to the postgraduate spine teaching series. And this time we have with us Dr. Ankur Nanda. He's a consultant spine surgeon and unit chief at one of the finest high volume centers in the country, the Indian Spinal Injury Center, with a renowned rehabilitation center as well. He's going to be taking a very basic and interesting and very important topic for all postgraduate residents. How do we approach any patient with thoracolumbar trauma? Over to you, sir.
Thank you, Rohan, for the kind invitation and introduction as well. I'm going to be, can you see my slides?
Not yet, sir. It's just,
yeah, just give me a sec. I think we just tried it just now. I know. Is that fine?
Yeah.
Okay, so I'm going to speak on thoracolumbar fractures today. And we know that in our residency, probably if we look at spine trauma, this is something which is the most common to see. And for any person who's aspiring to be a spine consultant or a spine surgeon, I think thoracolumbar fractures are something which is one of the most common surgeries which we'll be doing, or thoracolumbar fractures will be the most common patients which we'll be seeing along with the slip disc patients. So we are going to just talk here mostly about basic principles involved in the management, and basically every management of every fracture basically depends upon its mechanism of injury and its classification. So if we want to understand what sort of management needs to be offered to a particular fracture, you need to understand how that fracture has happened, and that will guide the management. So we will be looking at the classifications as well and some basic thing. So we know that, spine trauma has been something which was 4,500 years ago described as something which one should not touch, and once something which cannot be treated. But we know that now the understanding of spine and spine mechanics and the instrumentation and the technology available to us can help us in doing a lot of things. Spine injury is prevalent in trauma patients. Around 6% of all trauma patients would get a spine injury, and about half of these will get a spinal cord injury. So we need to understand these two things differently. Vertebral fractures and associated spinal cord injury. So fractures can happen without causing any neurological deficit when the spinal cord has been spared. And when the spinal cord gets affected, when the neurology gets affected, it is 50% of the times in a thoracolumbar fracture. So thoracic and lumbar fractures account for around 30 to 50% of all spinal injuries. And 60% of these fractures will happen at the thoracolumbar junction. Most of the injuries in India, at least, are most likely seen in males, and the mechanism of action is mechanism of injury is usually either a fall from height or it is a road traffic accident, especially a two-wheeler accident. Most commonly, areas affected are vertebrae affected are T11, T12, and L1, at least in 50% of the cases. Lumbar fractures, lower lumbar fractures would account for 1/3 of the patients, and a higher thoracic is usually a high energy trauma, usually will happen, fall from a very, very significant height or from a very high energy traffic accident. And these injuries can be associated with, hemothorax, can be associated with an intra-abdominal injury, like in a chance fracture, can have liver and splenic injuries and pulmonary injuries as well. Neurological deficit would be reported in approximately 15 to 20% of all thoracolumbar fractures or dislocation. That means around 80% of these fractures, patients will escape without any deficit, but in around 20%, they will have a deficit which may be complete or which may be incomplete. And we will understand what do we mean by a complete deficit or an incomplete deficit. Now, why does thoracolumbar fractures are most common, especially the TL junction? It's because thoracolumbar junction is a transitional zone. It's a transition between a stiff thoracic spine, which is supported by the ribs on both sides, followed by a mobile lumbar spine where majority of our spinal movements happen. And whenever there is a energy dissipation or whenever there is an accident, usually it's the junctional area which will get the maximum brunt. And that is why it's the thoracolumbar junction which gets usually affected. There are, one or two forces will act together. Either there will be an axial compression associated with the flexion moment, or there will be an extension injury along with a distraction injury, or there may be a dislocation or a shear or a translational injury. So there can be different force vectors leading to different patterns of injury. And we'll be talking about this one by one as we go along. So this is the neurological examination chart, and we know that this is the INSCI chart. If you don't know, this is something which is called the initially it was called the Asia Impairment Scale, and now it's called the INSCI chart, which is the International Standards for Neurological Classification of Spinal Cord Injury. And basically here, every key muscle supplied by a particular nerve root is given some points. So a normal muscle is graded as 5, and then right up to 0, where 0 means no power. So you are supposed to basically, when you examine the patient, we need to assess power in the upper limbs and in the lower limbs in each myotome. So C5, C6, C7, C8, and T1 in the cervical area, and L2, L3, L4, L5, and S1 in the lower limbs, which makes it a maximum of a score of around 50 in one limb, in upper limbs, and 50 in the lower limbs, which makes it a total of score of 100. So this way you can do a motor charting. At the same time, you need to mark the sensory involvement, and it can be marked as 0, 1, and 2. So 2 means normal, 1 means abnormal, or reduced, and 0 means there is no sensation. So you need to do a sensory scoring and a motor scoring, and this chart, if you fill it up, it gives you the complete neurological examination. Once you have done this charting, you will be able to say whether it's a complete injury or an incomplete injury. And how we decide that? So if a patient has a complete loss of power and sensation below the level of injury, below the vertebral level of injury, with no sacral sparing, which means even the sensations are not present in the sacral area, that injury is called as the complete injury. So why are we talking about the sacral area also? Because sacral segment is the last segment to be affected. And so the sacral sensations are the sensations at the anal mucocutaneous junction. Sacral motor function is voluntary and anal sphincter contraction on digital examination. So if you are able to see sensation in the sacral area, whereas the sensations may have reduced in the leg, then it qualifies as an incomplete injury. But if your sacral sensory area shows no sensation, or if the anal contraction is absent, then the patient will qualify as a complete injury. So incomplete injuries are partial preservation of sensory or motor function in the lowest sacral segment. So let's say if you have an injury at fourth thoracic vertebra or a fifth thoracic vertebra, and you have complete sensory and motor loss below that, including no sensation in the sacral area, then this injury will be a complete injury. On the other hand, if you have an injury again at T5, but the patient has a motor loss in L2, L3, L4 everywhere, but maybe the S1 is moving a bit, or an L3 is showing grade 1, then these injuries will qualify as incomplete injuries. At the same time, before we classify these injuries as complete injuries, we also have to rule out whether the patient is in spinal shock or not. So what is spinal shock? Spinal shock is basically depression of the spinal reflexes caudal to the spinal cord injury, and it happens due to the immediate depolarization of the axonal membranes from the kinetic energy of the injury, which disrupts cord function temporarily. The spinal shock is usually likely to resolve in 24 to 48 hours of injury, and is marked by the return of spinal cord mediated reflexes. So how do you check whether the patient is out of spinal shock or not? Bulbocavernous reflex is the first reflex to come back, right? So if you examine a patient where there is no sensation or power below the level of injury, but when you examine even the bulbocavernous reflex is absent, then that means that the patient is in spinal shock. However, if the patient has no power or no sensation below the level of injury, but bulbocavernous reflex is present, then that means that this patient is not in spinal shock, and then this injury qualifies as a complete spinal cord injury. How do you elicit a spinal bulbocavernous reflex in a male patient? You can simply do some compression at the glans penis, and this will, as a result, lead to a anal sphincter contraction, which can be felt with a finger held in the rectal area. In the females, it can be done by tugging of the Foley's catheter, which has been inserted, which would lead to contraction of the anal sphincter. So it is very, very important concept. We must remember this, that whenever we see a patient of spinal cord injury, and if the patient seems to be completely paralyzed, you must go ahead, check sacral sensations, anal sphincter contraction voluntarily by the patient, and bulbocavernous reflex. If the sacral sensation or voluntary anal contracture by the patient is present, patient is an incomplete injury. If the patient has has complete deficit, no sensory or motor power is there, and bulbocavernous reflex is present, that means the patient is out of spinal shock and has a complete spinal cord injury. If bulbocavernous reflex is absent, then probably the patient is in spinal shock, and you need to reassess your strategy. You need to wait for the neurology to come back. Also, it's important to understand these incomplete injury syndromes. I'm just going to enumerate them, not going to get into the detail here. So we know there's something called central cord syndrome, wherein usually the injury is more towards the center of the cord, which causes more weakness in the more weakness in the upper limbs, and lower limbs are usually better off or intact. Then there is anterior cord syndrome, when the injury is primarily in the anterior part of the cord. There is posterior cord syndrome, when the injury is on the posterior part of the cord, which usually leads to loss of proprioception and joint position, and also imbalance. And then we know the brown sequard syndrome, wherein there is ipsilateral involvement of the motor cortex and contralateral involvement of the sensations. Conus medullaris syndrome is also something which is seen with thoracolumbar fractures. So conus medullaris is the area where there is a transition from the upper motor neurons of the spinal cord to the lower motor neurons of the cauda equina. So here you can see usually a mixed picture of a LMN or UMN type of injury. You may have a bladder which is looking at UMN, but you may have a flaccid paralysis. And this will depend upon where the injury is happening, because this is the end of spinal cord, and the injury may happen in the conus or in the epiconus. How do we classify these fractures? It's very important to understand. But before that, we need to understand, why do we classify fractures? We classify fractures so that we can communicate to each other. Let's say you are on emergency and you see a fracture, patient has come, a T12 fracture, you need to inform your consultant or your SR or your senior. And what do you tell them? So you need to have a name, nomenclature of the fracture in mind to be able to exactly tell him what fracture we are talking about. So it can be a burst fracture, it can be a dislocation, it can be a chance fracture. So that is why for communication, classification of any pathology is very important. The second reason for classifications of any pathology is basically because majority of these classifications will guide treatment strategy. So if you have a compression fracture, this thing is to be done. If you have a burst fracture, probably you need to do a posterior stabilization. Or if you have a distraction injury, you cannot conserve them. You need to operate them. So something like that. So they always guide treatment. Third part is prognostication. Usually classification systems will also give you prognostication in terms of recovery, like as we classified complete injuries or incomplete injuries, or like we will see in certain classifications which follow, the lower grade of a classification may signify a lesser injury. A higher grade in the classification may signify a more severe injury. So these are the reasons why we do classification, and these are the key to management principles as well. Now, thoracolumbar fractures have evolved over the years from simplistic classifications to some complicated classifications. And why there are so many classifications which you may have read for thoracolumbar fractures is because some of them were either oversimplistic, or some of them were so in depth that they were too inclusive and complex. Some of them were not nicely reproducible. Like I may see a fracture and I may classify it as 10.1, and the other person may see the fracture and may classify it as 10.3. So that means that reproducibility of the classification also becomes very important. Reliability becomes very important, and it has to be practical in the clinical scenario. Now, if you look at the classifications, we started, back in Bowler's times, back in 1830, when he talked about, importance of injury mechanism, and he gave 6 types of spinal fractures which were included in the system, which classified the fractures into compression, flexion, extension, lateral flexion, shear and torsional type of. Then in 1938, the Watson-Jones classification came in, and he introduced the concept of stability, and he talked about fractures like wedge fractures, comminuted burst fractures, and fracture dislocations. So the morphological classification came in. In 1949, Nicol came up with a classification, and this was the first time when we started talking about, recognize the importance of posterior ligaments. So he reviewed around 150 odd coal miners fractures, and he found that there were 4 fracture types, and he classified them into stable and unstable injuries. The stable injuries were the ones where the posterior ligamentous complex was intact, and the unstable injuries were the ones where the posterior ligamentous complex was disrupted. So this was the first time back in 1950 when we recognized the importance of the posterior ligaments in the spine. So which are the posterior ligamentous complex in the spine? So we know that between the spinous processes, there is a ligament called the interspinous ligament, and between the tips of the spinous processes, there are ligaments called the supraspinous ligaments. And at the same time, between the lamina, there is the ligaments called the ligamentum flavum. So all these together, along with the facet joints and their capsules, along with ligamentum flavum, interspinous ligament, and supraspinous ligament, they all form the PLC complex, or the posterior ligamentous complex. Then we started, refining our classifications, and in 60s, people came up with the concept of 2-column concept, which was the Holdsworth and the Kelly-Whiteside classification. And first time in 1980s, Dennis came up with the classification, which was based on the 3-column concept. So Dennis, McAfee, and Ferguson and Allen classifications, which came in the 80s, were based on 3-column concept. Now we need to understand what is these columns. What are we talking about? So Nicol's classification talked about 2-column concept, wherein anything which was in the front on the vertebral body side was called as the anterior column, and anything which was behind, which means including the neural arc from pedicles to facets to spinous processes and the ligaments, was classified as posterior column. And they stress the importance of posterior elements in the stability of a fracture. Then Dennis came up in 1983 with the classification, which was based on the 3-column concept. And this is something which has been, stood the test of time and is still followed in a lot of centers all around the world. This classification is able to classify a lot of fractures and has done well so far, but it has its own limitations also. So how did they divide the column? So they divided the column into 3 parts. The anterior 2/3 of the body was called as the anterior column. The posterior 1/3 of the vertebral body, along with the posterior longitudinal ligament. So posterior longitudinal ligament is just behind the vertebral body inside the spinal canal. It was known as, so posterior 1/3 body with posterior longitudinal ligament was known as the middle column. And the posterior column was the all structures posterior to PLL, which means the neural arch and all the posterior ligamentous complex. With this classification, they came up with around 50 subtypes. So it had compression fractures, stable burst fractures, unstable burst fractures, dislocations, and distraction injuries. Then McAfee came up with the classification, which was again pretty busy, which was based on CT based, and they also stressed on the middle column. This classification, the load sharing classification, was the time which came up when the CT and MRI had already evolved. So if you see in the timeline just below, on the lower side of the slide, you can see that with advancing years, different types of classifications came in, and now the classification started changing because around 70s to 80s and early 80s, CT and MRI were evolving, and we were now better understanding the spinal anatomy. And so in the early 90s, load sharing classification was introduced, which was based on CT scan. And they reviewed injuries which were fixed posteriorly by a short segment. So short segment means 2 screws above and 2 screws below the vertebral body fracture. And they studied these fractures, and they found that when you did these fixations, short segment fixations, many of these fractures were failing. So this was the era of failure of short segment fixations. And what they found out was they devised a method of predicting which of these fractures would fail if a short segment fixation were done, and which of these will stand the test of time. So what they did is they divided the, so they looked at the comminution in the fracture, divided into 3 parts, little communication, 30% combination, 30 to 60% combination, and completely more than 60% combination. Then they also looked at in the CT scans how much the fragments had sort of displaced from each other, whether they were less than 1 mm displaced, whether most of the fragments were more than were around 1 or 2 mm displaced, or more than 2 mm displaced. And they also checked how much the kyphosis was correcting when these patients were laid prone on the operating table, how much the angle was getting corrected. Was the angle corrected less than 3 degrees? Was it corrected more than 4 to 9 degrees? Or was it corrected more than 10 degrees? And according to that, they gave score, and they found out that if the total score of this was less than 6, then usually a posterior short segmentation, posterior short pedicular screw fixation would be a successful surgery. But if the score was more than 6, then usually these constructs were likely to fail. And in these patients, they advised anterior surgery. So this is what the use of the load sharing classification was, which was introduced in the 1990s. Then the AO group, you know all about AO. You know we all have been trained in AO implants. We have been attending AO courses. So the AO classification came up after that, which was somewhere in the late 90s, and they divided the injuries into type A, type B, and type C. Type A injuries were mainly compression injuries. Type B were mainly distraction injuries, and type C were multidimensional, rotational, translational injuries. So when we say compression injuries, usually type A injuries, there would be breakage in the vertebra. Type B would be, there may or may not be fracture in the vertebra, but there would be a posterior ligamentous complex tear. And type C would be something like a dislocation. But the problem with this classification was that there was so many subtypes, it was practically impossible to reproduce it, to communicate with each other, and even memorize it. So clinically, it became irrelevant. And a lot of people studied with them, and there was a poor inter-observer reliability which was seen with this classification. The AO inter-observer reliability was only 0.31 on CT, whereas the Dennis inter-observer reliability was, which was an older classification, was much better. And so Vaccaro et al. Then came up with a classification system which was called TLICS system. And this classification system has been used over the last 15 years has been used by surgeons all over the world, and is pretty well accepted, even though it has its own fallacies as well. So the spinal trauma study group headed by Dr. Vaccaro, they came up with this classification called the Thoracolumbar Injury Classification and Severity Scale, known as the TLICS, and it looked at 3 components. It looked at the injury morphology. It also looked at the integrity of the posterior ligamentous complex. And first time in any of the classifications, the neurological status of the patient was also taken into consideration. So till now, all the classifications which we saw, either it was AO or Dennis or McAfee or Holdsworth or whatever they're on, none of these classifications talked about neurological status. So this was the first classification which talked about neurological status also. So not only did it talk about the PLC injury, it talked about the morphology and neurological status. And why I'm stressing on neurological status is because in these fractures, neurology is one of the most important factors which decides whether or not we are operating this patient or we are conserving the patient. And second, how quickly or early you want to operate these patients. So generally, an incomplete injury, you want to operate as soon as possible, even in the middle of night, because we know that the earlier we decompress these patients, more likely are their chances of neurological recovery and eventually great functional outcomes. But in complete injuries, probably operating early may not translate into such results with an incomplete injury, even though this concept is also changing with time. But as of now, incomplete injuries need to be taken in the middle of the night. So when we talk about these 3 components, what were these 3 components? First was injury morphology. So injury morphology, they gave different points. So compression injuries, wherein only the end plate fracture is there, was given 1 point. Burst injuries, wherein the fracture was both in the end plate and also in the middle column, was given 2 points. Translational injuries were given 3 points, wherein there is a malalignment of the vertebral column. And distraction injuries were given 4 points, wherein there is a complete failure of the posterior ligamentous complex. So you can see as the injury severity is increasing, the number of points being given to the injury was increasing. So this is a burst fracture. You can see that there is a involvement of the middle column. You can see there is a retropulse fragment. Also, you can see there is a widening of the interpedicular distance. So this is typical of a burst fracture, wherein you see a body fracture along with, in the AP X-ray, if you see widening between the interpedicular distance, then we know that this is a burst fracture. Whereas a compression fracture will not have any middle column involvement. It will not have any interpedicular distance widening, but will have only collapse of the end plate with middle column height absolutely normal. So that can be a superior end plate fracture or it can be an inferior end plate fracture. And in osteoporotic individuals, it can be end plate fracture of both superior and inferior together without involvement of the middle column. So the important differentiating point between compression fracture and a burst fractures are two. One, burst fracture will have a middle column involvement, which means the posterior border of the vertebra will lose its height. And second, on the AP X-ray, there will be an interpedicular widening. So we need to, it is very important to differentiate between these two fractures because the pathology is very different. So you can see in this CT scan, there is a retropulsed fragment behind in the posterior-superior part of the vertebra. This is a burst fracture. In compression fracture, you will not have this piece. Even if you see the axials, you can see that, the fracture is traveling through the vertebral body, and you can see this with the yellow arrow here, you can see the retropulse fragment which has come into the canal. Along with these burst fractures, there can be vertical lamina split fractures also in some of the cases. This is not unstable necessarily, but you can see these green stick fractures of the. So this is a typical burst fracture which you can see, and you can see the retropulsion of the fragment and getting into the canal. Then there can be translational or rotational injuries wherein you can see displacements of one vertebra over other. So there may not be any significant vertebral body fracture in these injuries, but there will be facetal jump as well as a malalignment of the vertebra. Third injury is the distraction injury, wherein the vertebra may or may not get fractured, but you can see the posterior column has opened up and there are fractures which have come in on the posterior elements, either in the pedicles or in the spinous processes. So it is important to differentiate these fractures from burst fractures. So burst fractures will have a vertebral body fracture, but will not have a posterior ligamentous complex which has been torn away. But with these injuries or the distraction injuries, there may or may not be a body fracture, but there will be distraction of the posterior ligaments. So you can see there can be distraction like this, wherein the vertebra have completely separated out. Integrity of PLC is something which also given as 0, 2 or 3 points. So 0 means if there is no PLC injury. 2 means if there is a suspected injury, which can be seen on the MRI as hyperintensity on stir images, or what we know also call as fat suppress images. So remember, MRI has three series which we do. We do T1 weighted images, we do T2 weighted images, and stir images. So what are T2 weighted images? So to remember, you have to remember this. T2 weighted images, water is seen white, which means that when you see the spine MRI and you can see CSF white in color, then that is a T2 weighted image. T1 weighted images, water is seen black. So if you see a MRI film and the water is black in color, then that is a T1 weighted image. And then there is a fat suppress image. In fat suppress image, the fat will also look black. So in T2, water is white, fat is white. In T1, water is black, but fat is white. In stir, the water is white, but fat is black. So stir images are the best to see posterior ligamentous complex injuries, because the moment the posterior ligamentous complex burst out, there is a lot of edema which will happen in that area, and you can see discontinuation of the ligament. So if the stir images show a lot of edema in the posterior ligamentous complex area, then that means mostly the ligaments have torn. So they can be called as suspected injuries, or if you can see clear-cut disruption of the ligament, then it is definitely injured, and you can call it as 3 points for this. Neurology is also given points. So if there is intact neurology, you want to score it low, which means 0. Nerve root injury, again, they are minor injuries, so they are given only 2. Incomplete injuries are given more points than complete injury, because incomplete injury, that means you need to definitely operate, because these patients are more likely to improve neurologically than a complete injury, wherein complete injury, we know that the chances of recovery are less than 1%. So incomplete injuries, caudal equine injuries were given 3 points, complete injury was given 2 points, nerve root injury was given 2 points, and intact was 0. Now, once you have put the score together, any patient who scores less than 0 to 3 may be treated conservatively. Any patient who scores more than 4 can be treated surgically, and any patient who scores 4 can be left to the individual discretion of the surgeon whether he wants to go ahead and operate. So basically, this score helps us in deciding whether you want to undertake surgery for a particular patient or you want to not operate that patient. So this is the first classification which looked into the neurology and also helped us in deciding whether the patient needs surgery or not. In the meantime, the AO classification, AO group got together and they have also improved their classification. And this is the newest classification which now all of us are using. And this is something which has tried to address all the fallacies of the previous classifications and has tried to make it more simple. And I'll show you some charts which will probably simplify things. So this is the AO spine thoracolumbar spinal injury classification system. It's a comprehensive classification, yet simple, and it has a clinically acceptable inter-observer and intra-observer reliability. So this is the classification, and if you look at this, it looks a little bit complicated. But it has a part, the type A part, A1, A2, A3, A4, and then it has a B1, B2, B3 part, and then a C part. Now let me just hide some of these parts, and then it will be very simple for you. So if we go like this. So these are the type A injuries, and you can see that the classification is simple from A0, A1, A2, A3 to A4. Now let's look at them individually and you will be able to very easily remember. A0 means minor fractures, non-structural fractures, like, a spinous process fracture or a transverse process fracture of the thoracolumbar vertebra can be classified as A0. A1 is the end plate fracture, wedge compression fractures, which means there is no middle column involvement, there is no posterior column involvement, only the end plate is fractured, which is called as A1. If there is a split fracture, so many a times what happens is the vertebral body doesn't crush or doesn't go into pieces, it just breaks into 2 pieces. It's called a split fracture. So if either it can be a coronally split or it can be a sagittally split fracture, and both these fractures actually will not involve the middle column. So it will involve the superior and inferior end plate both, but not involve the middle column. These are called as the A2 fractures or the split fractures. Now, A3 is the incomplete burst fracture. So what is the difference between an incomplete burst and complete burst? So it's a 2-column injury wherein the middle column is involved. But when only one end plate is involved, it is called incomplete burst. And when both end plates are involved and there is severe combination of the middle column, it's called complete burst. So A3 is incomplete burst, A4 is complete burst. So it's simple, A0 to A4. Now you look at the posterior ligamentous complex. So there are 3 types of injuries which are possible in the distraction injuries, B1, B2, and B3. So what are those? So B1 injury is a purely bony injury. B2 injury is a soft tissue injury wherein the posterior tension band disruption is there. And B3 is the distraction injury, but instead of the distraction happening with fulcrum in the anterior part, the distraction is happening with the fulcrum in the posterior part. So it's a basically hyperextension injury, usually seen in cases like ankylosing spondylitis or dish, basically in fused spine. So if you look at B1, B1 means a typical chance fracture. What is chance fracture? Chance fracture is a fracture which is a distractive injury wherein the fulcrum is on the anterior border of the vertebra and the vertebra fails in distraction in the posterior column. So what will happen is the spinous process will split, the fracture will advance, it will split the pedicles, the fracture will advance again, and it will split the vertebral body into 2 halves and open up the vertebral body like this. This is known as a typical chance fracture, and it's the B1 injury. Herein, no ligament has got involved. The fracture has traveled through the spinous process, passing through the pedicle into the vertebral body, reaching the anterior vertebral cortex. Now, B2 injuries are similar injuries, except for the fact that here the injury is not purely bony. So there can be posterior ligamentous complex disruption, there can be facet capsule disruption, there can be ligamentum flavum injury, there can be disc injury. So this may be a bony ligamentous injury. It's a mixed injury, but the mechanism is the same. And then B3, as I said, is a hyperextension. So now we have type A injuries, which were mainly about vertebral body fractures, type B injuries, which were mainly about posterior ligamentous fractures. And third is the type C, which is the translational injuries. Now, these are the injuries wherein the alignment of the bone is gone, either in the frontal plane or in the sagittal plane. So you may have a dislocation, or you may have a horizontal dislocation, or you may have shear injuries. So whenever you see vertebral column completely malaligned, it's a type C fracture, and this is the worst type of injury, and this will require a very long fixation. Whenever you see the alignment is maintained, but the spine has gone into a lot of flexion with not much of vertebral body involvement, usually it will be a distraction injury. And then the idea will be to put screws on behind and rebuild the posterior tension band. And whenever you see a fracture which has a lot of vertebral body involvement, the vertebral body has broken down, it is a compression injury. And then you want to check the posterior ligaments, whether it's associated with a distraction injury or not. So anterior compression injury may be a standalone compression injury, or it may be associated with a posterior distraction injury. Whereas translation injuries, whereas the translation injuries will always have all three columns involved. I hope I've made that clear. The other part of this classification is the neurology, wherein there is N0, N1, N2, N3, N4 marking, depending upon what type of deficit is there, incomplete or complete. They also have something which is called the NX, which means that the neurological status is unknown. And this is usually in the patients who have got a head injury or sedated, and they are not able to respond. So basically, if you write in the classification that AO type A3 NX, that means that this patient is not responding to your verbal commands. And then there are certain modifiers, M1 and M2. M1 is for the patients where the spinal imaging could not clearly say that whether the posterior ligament complex is gone or not. And M2 is in a specific patient-specific morbidity like ankylosing spondylitis or burns on the overlying skin. That also can be sort of documented. The algorithm for morphological classification, how this classification leads to deciding which injury it is very simple. So you can see if there is any displacement or dislocation. If there is a dislocation or displacement, it's type C, as we were talking about. If there is no displacement, look at the tension band. If the tension band is disrupted, and if it is an anterior tension band disruption, it's B3. If there is a posterior tension band but purely osseous, it is B1. If it is osteoligamentous, it is B2. And then you look at the vertebral body fracture. If there is a posterior wall involved, if there is no posterior wall involvement, then it is if there is no vertebral body involvement, it is either a transverse process fracture or a spinous process fracture. If there is a body fracture but posterior wall is not involved, then it's an end plate fracture, which makes it an A1. If the posterior wall is involved, then it can either be an incomplete or a complete burst. So asking these simple questions can help you in guiding which type of classification or which type of fracture is this. So according to these classifications, which are the stable fractures? So compression fractures, stable burst fractures without any deficit are usually without any deficit and without any significant kyphosis are usually stable. Unstable fractures are the ones which are unstable burst. Any chance fracture or a posterior ligamentous flexion distraction injury is an unstable injury. Any AO type C translational rotational injuries are unstable injuries, or any hyperextension injury, which we were saying type B3, they are unstable injuries. What are the treatment goals for these fractures? If you just quickly go through the management principles, the treatment goal is to have a stable, well-aligned spine, also regain neurogenic stability and early functional recovery. What are the decision-making factors to decide whether a patient needs surgery, and if surgery, what type of surgery? It would be neurological status of the patient, whether has a complete, incomplete, or no deficit. Type of injury, whether a stable or an unstable injury. How many days since surgery or how many hours since surgery, since injury is also something which is very important. Associated injuries, comorbidities, age and activity level of the patient will all help in deciding. Non-operative treatment is usually offered for patients with stable fractures or patients with fractures which are morphologically stable and also have intact neurology. There's no deficit, or in patients who are not fit for surgery or have a lot of comorbidities. How do we do non-operative treatment? You can initially give a short period of 5 to 7 days of rest along with analgesic, and once the pain is reduced, you can get the patient up, stand, and see standing X-rays. If on getting standing, the pain is increasing significantly or any neural deficit or radiculopathy is appearing, then probably we need to reassess whether the patient needs surgery or not. However, if on the standing X-ray, the pain is okay, the collapse on the X-ray is controlled, then patient may be considered to, sort of mobilize with brace. Different braces can be used. And then with the brace, you can use a TLSO brace. And with the brace, you need to do serial X-rays at maybe 3 weeks, 6 weeks, 12 weeks, just to see that there is no significant collapse happening, or there is no late onset kyphosis or late onset deficit which is appearing. Brace weaning is initiated once there is clinical and radiographic evidence of clinical healing. What are the indications of surgery in this? So any patient with a neurological deficit, any type B and type C unstable fracture, or a type A injury with neurological deficit would usually qualify for. So then if you see here, if we look at the AO classification, type B means all distraction injuries, which are ligamentous injuries, will require surgery, except in one scenario, which is that scenario, which is the type B1, which was by type B1. Type B1 was the typical only osseous injury, the chance fracture. So if it's a pure bony chance, these patients can be treated with brace or can be operated. Otherwise, all type B and type C injuries will require surgery. And in type A injuries, any patient with neurological deficit would require a surgery. At the same time, if in a type A injury, there is a loss of height of more than 50%, kyphosis of more than 30 degrees, or canal narrowing of more than 50%, usually these patients also would require surgery. For an incomplete spinal cord injury, as I was saying before, cauda equina syndrome, urgent surgery should be done. Early decompression can lead to good functional outcomes. Complete injuries, surgery is aimed for early rehabilitation, but the recent studies and recent literature has suggested that even in complete injuries, if the patients have come to you within 8 to 12 hours of coming, then a fair chance of recovery should be given to these patients, because a small minuscule of percentage of patients may improve. So complete injuries presenting very early in the hospital may still be subjected to urgent surgery, but all incomplete injuries need to be subjected to urgent surgeries. So the surgical principles are to maintain anatomic reduction, minimize construct length while providing sufficient stability, neural element decompression, and avoiding complications. How do we do this? We can do it by different approaches. We can do an posterior approach, we can do an anterior approach, or we may do a combined approach. Now, every approach has its own indications, and different injuries would require, can be done by different approach. So we look at these one by one. So posterior approach is required in all type B and type C injuries. Why? Because we know that type B and type C injuries involve injury to the posterior ligamentous complex. And if the posterior ligamentous complex is disrupted, it must be, made again by restoring the tension band on the backside by a posterior construct. So if you manage a type B or a type C by an anterior approach, it is most likely to fail. So for type B and type C, posterior approach is a must. So this is one of those fracture segment fixations wherein you can put screws in the fracture vertebra also. Now, anterior approach is usually used for burst fractures where there is a severe collapse of the anterior column. And according to the load sharing classification, as we discussed at that time, there were 3 categories. We are divided into 9 points: less than 6, only posterior; more than 6, anterior reconstruction required. So those patients, you can do anterior approach. You can do either standalone anterior, or you can do anterior plus posterior. So there are certain instrumentations which are available initially called the Canada plate and the anterior plate, where you could do standalone anterior fixation also in a unstable burst fracture. But majority of the times now the practice is changing. Anterior approaches are now being done less and less for these fractures, and usually majority of the surgeons are managing these fractures from behind itself. But although anterior can be done for them, anterior plus posterior approach is usually reserved for patients where there is a lot of displacement, there is a lot of trauma to the ligaments, and this complete translocation with complete loss of body. This is where we usually do an anterior plus posterior approach. How can the stability of a posterior only approach be increased in cases of a badly comminuted vertebral fracture? There are different ways. Either you can go ahead and do a approach anterior from posterior only, or you can start putting pedicle screws at the level of fracture in burst fractures, which is called the fracture segment fixation, which is shown to have very good results, almost comparable to anterior vertebrectomy and cage fixation. You can do some vertebral shortening. You can augment the anterior vertebra by bone graft, or less commonly by cement in osteoporotic patients. Also, what is very important to understand, the length of construct and what are these short segment and long segment construct. So when we say short segment construct, what we mean to say is one level and one level below the fractured vertebra, you can put pedicle screws one level above and one level below. So total 4 screws, one up and one down, is called the short segment fractures. And these can be used for burst fractures without any significant ligament injury. Long constructs, long segment fixations are the ones where we go 2 level above and 2 level below. So there are 4 screws above and 4 screws below the injury. And usually these type of constructs are used for type C rotational injuries, severe type B injuries, translational injuries, or if the patient has significant osteoporosis. The third construct is the fracture segment construct, which is gaining a lot of popularity now. This is a 6 screw construct basically. So let's say if you have a D12 burst fractures, then you put 2 screw in D11, put 2 screws in L1, and also try and pass 2 screws into the burst fracture itself, D12, so that when you sort of connect them with a rod, there's a lot of stability which is afforded by a screw going into the fractured vertebra. And this has stood the test of time and has obviated the need of a vertebrectomy or corpectomy of the fractured vertebra in majority of the cases. I think with this, I'll end my presentation. And I'll be very, very happy to answer any questions or if there are any doubts.
Yeah.
Thank you.
Yeah. So thank you, sir, for an excellent and elaborative talk on these fractures. I would request the residents to come up with any questions if you have for Dr. Ankur, please. Is there anybody who wants to ask any questions?
So I would encourage you to ask any question which you may find silly or you've not understood. If you want me to go back to any slide and understand, I'll be happy to do that. So please feel free, don't feel anxious.
Yes, so I'll just start with one question myself. I think these people, by the time they come up with something. Sir, what is your threshold to operate on, say, a TLICS 4? Like, the ones where you can conserve or like operate, where a surgeon is actually stuck borderline whether to conserve him or operate him. What is your this thing?
So Rohan, thanks for the question. And when I was talking about TLICS, I wanted to sort of touch this part, the 4, but then I thought, okay, let me not complicate. So because the idea of these lectures is to basically give some information and not confuse people further. And this question actually puts a lot of confusion. So I'll try to answer that. So basically, what Rohan is asking is, because the TLICS score says that anything which is below 3 doesn't need to be operated, anything above 4 needs surgery, but at 4 it is the surgeon's discretion to decide whether he wants to operate or not. And usually, what happens is, when you see a fracture in the clinic and when you see a patient, usually you don't have doubts for less than 3s and more than 4s. You don't need to do this scoring. You immediately know that whether you're going to operate or not. The only time you get a confusion is when the patient is at 4, and this is where the TLICS doesn't answer what you want to do. So let me put it this way. So usually a patient who is ending up in TLICS 4 will not have a deficit. And if he has a deficit with TLICS 4, absolutely surgery needs to be done. But usually that case scenario doesn't arise. Now TLICS 4 can be there, let's say, in a scenario wherein there is a burst fracture, which makes it 2. Or if there is, along with that, if you look at neurology, usually a burst fracture will not have a root injury. So neurology, so on the ligamentous part, probably if the ligament is looking suspicious, which is again 2, then that makes it a TLICS 4. And this is where you will be confused whether I should operate or not operate. Then in that scenario, what you can do two things. Either you go down to your basics before, which I had talked about. If there is more than 50% loss of vertebral height, if there is more than 30 degree of kyphosis and there is more than 50% canal encroachment, I would usually think to sort of operate these patients. But at the same time, if these are not there, I would talk to the patient. I would tell him that, okay, we are going to repeat an X-ray maybe at 10 days to 12, 14 days, get you up and see if he sort of deteriorates in his alignment significantly at 2 weeks. And if I feel that he's significantly deteriorating, then that means he has a PLC injury, which we couldn't identify and was indeterminate. And I would then go ahead and get the surgery at that point of time. So I think that is how I'll handle it.
Yeah, thank you so much, sir. Anybody else who wants to ask any questions?
Sir, one question, please.
Yeah, sir, go ahead.
Sir, how do we differentiate on radiology basis between A1 and A3? The single end pit bus compression and wedge compression.
Yes. So I'm glad that you were able to come up again with the classification numbers. That means that we've got something across. So let's go through that A0, A1, A2, A3, A4 quickly, and then I'll explain. So we know that A0 is only a appendage fracture, which means there is no vertebral body fracture. So that is absolutely clear. Now we know A1, A2, A3, A4. Now A1 is only an end plate fracture and A3 is a burst fracture, right? Now A3 is a burst fracture, and so by definition the middle column will be involved, whereas in A1 only the end plate will be involved. So what you need to go do is you need to see the posterior border of the vertebra on an X-ray. So if you only have an X-ray, you need to do two things. You need to see whether the posterior vertebral border is of the same height as the vertebra above and a vertebra below. If it is of the same height, then this is more of an end plate fracture and not a burst fracture. That is one, but this is not foolproof. Second, go on to the AP X-ray, see if the pedicles have widened. If there is no widening, it's a compression fracture. If there is widening, it's a burst fracture. Okay. Third, many a times on X-ray, you would think it's an end plate, but actually if you do a CT or MR, you will realize that a small amount of, there is a posterior fragment which has moved posteriorly and started pushing the equina. So these can be missed on the X-rays. So that is why we always tell that don't consider compression fractures as innocent fractures and always investigate further to make sure what you are dealing with. I hope that that answers your question, Batsal.
Yeah, yes, sir. Thank you, sir. Yes, sir.
Yeah, so thank you, Batsal. Does anybody have any more questions for sir before we wrap it up? So I think no. So one more sir question just for the viewers.
Sure.
I will just go ahead. What do you do when you have a canal compromise of more than say 50% on radiology, but the patient is neurologically intact? Do we decompress or do we not decompress? Just for the knowledge part.
Sure. So if you have more than 50% canal compromise, so the classical teaching used to be, as I had written in the slides also, 30 degree kyphosis, 50% vertebral body height loss, and more than 50% canal encroachment, you should go and decompress. But frankly, in our experience, and because I'm from Spinal Injury Center and we see a lot of trauma coming to us, if the patient has intact neurology, even if then your canal compromise is more than 50%, you may not go ahead and decompress that patient, because usually the patient will remain okay. And then in the long term, there is something which is called canal remodeling. So even though it looks stenotic as of now, but with time and with the pulsations of the dura, this canal usually remodels and this compression becomes lesser. But you have to understand, this comes only with the, let's say, caveat that there is no instability. So by chance, if you have a more than 50% canal compromise, but there is also a ligamentous injury, then I would be very, very wary in not operating that patient. Then I would definitely operate. I may not decompress the patient during the surgery, but I'll definitely fix him.
Yes, sir. Yeah. So I think it's almost 9 now. And thank you again, sir, for your wonderful lecture and, removing time for us. and enlightening our viewers as usual. And we hope to see you soon again for some other topics as well. So
Yeah, Rohan, it was absolute pleasure. I know we are a little late, and it's a long day for everybody, but it was a absolute pleasure to be here. And I'll like to be here again whenever you guys need me.
yeah, thank you, sir. Thank you so much.
Thank you, everybody. Good night.